Sorry, no. Okay, welcome everybody to this conversation around febrile illnesses and particularly a series of studies that we're doing that are called the Diagnostic Use Accelerator. So this is a conversation and a video series that we're putting on as part of the Malaria and Fever program at FIND. FIND is the Global Alliance for Diagnostic. We're based in Geneva, and the vision and mission of FIND really is to accelerate the access, the development, and the use of diagnostics in resource-limited settings. And this specific series is really around the work that we're doing in the Malaria and Fever program. And this specific talk today and the conversations we're having today is about the role of diagnostics as part of a package to improve the management of febrile illnesses and treatment and the use of antibiotic in low and resource settings. And this is part of a number of studies that we're doing and a number of initiatives we're doing at FIND to really utilize diagnostics to improve the use of antibiotics and ultimately impact antimicrobial resistance by reducing the overuse of antibiotics. We have a great lineup today of speakers from around the world, giving us an overview from their experience as part of being part of the Diagnostic Use Accelerator. And I want to introduce the speakers ahead of time, but obviously again, when they will speak, first of all, we have Dr. Juvenal Mekaramahame. He's part of FIND based in Uganda, but coordinating the study from our end at FIND, the Diagnostic Use Accelerator. And he will be giving an overview of all the work and the vision of this program and really how we see this to impact AMR and the use of antimicrobials to optimize treatment. We have Dr. Francois Kimde, who is the lead for the study from the research unit in Anaro in Burkina Faso, who will give us an overview of the experience and some preliminary data of the study in Burkina Faso. And then we have Dr. Olita Shilpaka, a part of the emergency medicine unit in Nepal and Okru in Nepal, and she will be giving us some experience and showing some experiences from the work in Nepal, all part of the overarching Diagnostic AMR Use Accelerator, which is a study really run in 5 countries. So these 2 teams are representing the other 5, and we're very happy that they're willing to do this and giving their experience. In addition, in the panel discussion later on, we will have Mr. Philip Horgan, who's leading the social science aspect of this work. And I'm happy and really excited to talk with all of them later in the panel about how to move this exciting research forward and translate it into reality. So my name is Sabine Dittrich. I'm heading the work on febrile illness and malaria at FIND, and I'm excited to walk you through this webinar. The first talk is from Juvenal, who will be talking about the overall vision and the overall study design. And I hope that then that will be leading us really nicely into the experience from the 2 countries and then into the panel discussion. So please, Juvenal, take it from here and give us an idea of the overall study.
Good morning, good afternoon, and good evening from wherever you are. Juvenal Keramahame. I'm the Clinical Trial Project Manager at the Foundation for Innovative New Diagnostics, currently known as FIND, the Global Alliance for Diagnostics. I'll be presenting to you about a project called the AMR Diagnostics Use Accelerator, which is a project aimed to improving care of febrile illnesses and to attain the dual goal of fighting antimicrobial resistance and achieving universal health coverage in low and middle income countries. All right, as we already know that where access to diagnostics is limited, health workers tend to prescribe antibiotics just in case patients have fever due to bacterial infections, even in cases where patients have confirmed malaria or other viral infections. Health workers are kind of in the tradition of prescribing empiric antibiotics, and at the same time, patients who would require antibiotics actually may miss them So it is very important to have diagnostics, and this would help in tackling AMR and achieving universal health coverage. Since the advent of the COVID-19 pandemic, antibiotic prescriptions have been reported for even mild cases for which WHO does not recommend the antibiotics, and the absence of affordable diagnostics, even for COVID-19 and other causes of fever, is a major cause of these empiric prescriptions. In line with this challenge, we designed a study, and the question we are asking is, can we use a package of interventions to improve the management of acute febrile illnesses and better target the use of antibiotics, or reduce antibiotic prescriptions among children, adolescents, and adults who are presenting to outpatient clinics with acute febrile illnesses at the primary health centers in low and middle income countries. So in this study, we are looking at children and adolescents who have these undifferentiated fevers, and then we are giving them a package which involves rapid diagnostic tests which are currently available in the country. And then we are combining that with improved clinic flows. Then we have a training and communication package based on social science. And then we are comparing this with the standard of care that is already available in these countries. And then we are looking to see if this package of interventions is going to improve management of these illnesses and then reduce antibiotic prescriptions. This study involves about 20,000 participants from 5 countries, and we have about 8 sites. And we have this package of interventions, and then we assess the impact of the intervention at a period of 7 days. The study is unique in that we have protocols that are harmonized, but then they have differences depending on the country in which we are evaluating this study. The countries involved are Burkina Faso, Ghana, Uganda, Nepal, and India. Then the objective of the study, we designed it in a mixed methods design. So we had a baseline social science study to explore the behavior factors that affect healthcare workers' behavior in prescription. Then we are also exploring the patient's adherence to prescriptions. And then we use these findings from the baseline study to design a training and communication package that was rolled out in the intervention arm of the clinical trial. And then we have the intervention package, which involves all these components that I've mentioned, and then a follow-up of about 7 days. So we have a mix of different settings. Some of the countries have rural district hospitals, others have rural primary health centers, and other sites have referral hospitals, which are at the top of the health system. The reason behind this is to have a mix of different settings to increase the generalizability of the findings of the study. So in the social science, as I've mentioned before, we started with a baseline study to evaluate patient behavior and health worker prescription behavior. Then we used the data collected from that to design a training and communication package, which we use to train patients, caregivers, and health workers on how to prescribe, how to engage with patients, and then how to adhere to health worker prescriptions. This was during the clinical trial phase, and this was done at the day 0, which is the enrollment day. And then after a period of 7 or plus or minus 2 days, we would assess these patients to see who had better outcomes and who had better adherence to prescription. And at the end of the study, we are going to use the behavior change review process to design recommendations for future policy uptake. So this study is, for the main trial, we have patients come when they are eligible, they are random, they are consented and randomized, the 1:1 ratio, and they get into the intervention arm, which has different tests that are tailored to the epidemiology of fever in the country. And for the phase 1 of the study, these tests excluded any COVID-19 tests. And starting with September this year, we started including COVID-19 antigen RDTs as part of the package of tests. Then these tests include influenza tests, which is a common, influenza is a common cause of fever. Then we have malaria tests, we have group A strep pneumonia tests, we have SARS-CoV-2 as part of the phase 2 study, we have dengue, we have scrub typhus, we have leptospira, we have chikungunya, and all these tests, the package is determined based on the local epidemiology of the fever. So you will find in Burkina Faso the kind of tests that are being used, the package is different from the package that is used in India because of the different fever causes that are expected. In addition to that, we have biomarker tests, which are used when these other pathogenic tests are negative, and we can use these to guide antibiotic prescriptions as detailed in the clinical decision aid. Then just to clarify the differences between the phase 1, which happened before COVID-19, and the phase 2 of the study, which has happened during COVID-19, is that phase 1 occurred in Uganda, Burkina Faso, Ghana, and Nepal. Then India hadn't started when COVID-19 pandemic began, and then we amended the protocol to include the COVID-19 test in the algorithm. So currently, Uganda, Ghana, and Burkina Faso have enrolled more than 5,000 participants. Nepal is also enrolling participants under the phase 1 protocol, which excluded the COVID-19 test. And then India has included more than 600 patients under the phase 2 protocol, which includes COVID-19 tests. We plan to extend this phase 2 to the African sites, which recruited participants without COVID-19, and the protocols have been submitted to the different local and international IRBs for approval. But some we have learned, even before we analyze the data finally, we have learned some lessons, especially from the qualitative research. And these include that there are some drivers of behaviors which hinder or support adherence to prescriptions. And we urge that policymakers, clinicians, and so forth should factor these. And they include the affordability of prescribed medicines. If medicine is not cheap enough the prescription won't be adhered to. Influence of family and friends in cases where friends or family tell a patient that this medicine doesn't work, they may not adhere to the prescription. In some cultures, people believe that traditional medicines are more effective than the synthetic medicines. Then patients, some of them may believe that once they feel better, they are cured, so that they stop adhering to the prescription. Then there are issues to do with health workers. Some may not have time, some may have limited skills on how to engage participants, how to educate participants about the role of antibiotics and why we should adhere to antibiotics. So finally, it's been difficult conducting a large-scale multi-center study during the COVID-19 pandemic. There's been a lot of challenges with patient recruitment, with obtaining supplies, and so on. But what we've learned from this study, we've learned that still during the COVID-19 pandemic and other similar challenges, you can conduct clinical research in low resource settings, very remote peripheral health centers with limited resources, and still have almost zero lost follow-up among your participants. But then this has to do with how you manage your study team and how they engage with your study participants and what innovations you take up to ensure this. Then it is very important to integrate social science with clinical research. And this is something we've attempted to do in this study by incorporating biomedical interventions like point of care tests and social science interventions like the training and communication part. This is very important because we've seen that adherence to be it antibiotic prescription, be it any interventions, is driven by many factors which are context specific. Even if you have overlap between different countries, there are some major differences that have to always be taken into consideration by health workers, policymakers, and any other persons that may want to have an impact on AMR. I thank you all. That comes to the end of my discussion.
Thank you very much, Juvenal. I think this was a fantastic presentation to set the scene and to give an overview of the protocol and the overall vision and mission of the study of the Diagnostic Use Accelerator program and the individual studies, where they set and how they're organized and how they're implemented. Now I have the great pleasure to introduce Dr. Olita Shilpaka from the Oxford University Clinical Research Unit in Nepal, and she will give us some experience from Nepal implementing and working on this specific study. So thank you very much, and please take it away.
Thank you so much. First of all, good morning, good afternoon, good evening, namaste from Nepal. Thank you so much for this opportunity. I'm Dr. Olita Shilpakar. I'm from Oxford University Clinical Research Unit, Nepal, and I'll be talking about the experiences and the scenario in Nepal. So to begin with, so if I have to talk about febrile illnesses in Nepal, we all know that South Asia accounts for a significant proportion of the global burden of infectious diseases, and febrile illnesses is very common in a low-income country like Nepal also. And just a bit about the differential diagnosis of undifferentiated febrile illnesses in Nepal. Typhoid, of course, tops the list, both Salmonella typhi and Salmonella paratyphi. Also, the recursive infections like murine and scrub typhus, dengue, leptospirosis, malaria, and also viral infections like influenza. And the incidence, if we have to talk about the incidence of enteric fever, is the most common bacterial infection all over South Asia, with the incidence of about 500 per 1,000,000. So, antimicrobial resistance in Nepal, the previous slide. So there is a high burden of AMR in Nepal as well. So the reasons are pretty much obvious. Say inappropriate use of antibiotics, or just in case antibiotic prescribing practice here that is evident in this country as well. And the OTC drugs, the over-the-counter drugs, they're easily available all over the country. And there's drug resistance as well that is rapidly rising. I would like to mention that Salmonella typhi strains and even paratyphoid fever that are resistant to drugs like fluoroquinolones are slowly growing. So it is very, very difficult actually to treat these cases with antibiotics. And also in Nepal, comprehensive findings or studies are very, very limited in antibiotic resistance. So it is very challenging to manage febrile illnesses in low-income countries like Nepal. A few of the challenges I would like to mention are, knowledge gaps, or there's no awareness among the people or even the physicians about the differential diagnosis of febrile illnesses. There are no facilities. Specifically, diagnostic facilities are very, very insufficient. The point of care diagnostic kits are not available all over, and they are expensive as well. So if I have to talk about the devastating earthquake that took place in April 25, 2015 in Nepal. So what happened was that there was an outbreak of typhus at that time, maybe because of the poor awareness of this disease. This particular disease, when people came with fever, history of fever, they were tested by a non-specific test for typhoid, like a Vidal test, because even like simple tests like blood culture, they are yet not available in many health facilities in Nepal. And so these cases, typhus cases, they were even treated with ceftriaxone. So if I have to talk about the AMR diagnostic use accelerator, the study that is going on in Nepal, it started from February 2021, and it is being done by Oxford University Clinical Research Unit, Nepal, here at 2 different sites currently, in Pan Academy of Health Sciences and in another hospital, Nepal Korea Friendship Municipality Hospital. So this study, we all know, it assesses the impact of the improved RDTs, and this includes the COVID diagnostics as well. And also it talks about the practices, training, and communication packages on the fever management, and also the clinical outcomes among the patients that present with fever. So a bit on the impact of COVID here in Nepal. It is a real challenge, of course, not only in Nepal, but also globally. And we also have, like the WHO guidelines, Nepal also has a guideline on COVID-19 management, which clearly says that there should be no antibiotics for 19. But despite the guidelines, despite the message that is going around, there is still a high antibiotic prescription rate that is reported. And so there are a few challenges after COVID, the impact of COVID, I should say. The marked reduction in the enrollment of numbers have been there due to the pandemic. So maybe it is because of the reluctance of the patients to visit hospital, because of the fear of acquiring infections, the OTC drugs, as I mentioned earlier, the empirical treatment, and also there is absence of diagnostics here. So these are the key challenges, I should say. So there have been a few changes to the protocol, as mentioned earlier as well. The protocol amendment is going on. The protocol is being amended so that the sample size has been reduced to an achievable target, I should say. So here, what we have considered is for the enrollment, mild COVID cases with rapid diagnostics for COVID-19, also rapid diagnostic antigen tests has been considered. And if I have to give the number, till November 2021, there have been 144 patients, 71 in the intervention arm and 73 in the control arm. And talking about the changes to the protocol, even in a follow-up case, especially in the qualitative part, we have started phone calls for the follow-up cases. So the qualitative component, this actually is the first ever study, I should say, which in Nepal that is being done, which includes both the quantitative as well as the qualitative component. So this includes the training and communication package, and also the future behavior changes intervention. And this also helps to understand the barriers, like adhering to the instructions given by the doctors to the patients, or to the caregivers while prescribing antibiotics. Also adhering to new practices by the physicians, all the health workers, and also giving trainings or communication to the patients by the healthcare workers. So what we expect from this study, or what are our hopes from this study, it is for sure the better management of patients ranging from children to adults coming to the health facilities, like the outpatient facilities, also in the peripheries in Nepal. And I would also like to mention that the hopes or what we expect from this study is that maybe the easy availability of reliable RDTs, proper use, or let's say unnecessary use of antibiotic prescriptions, and also does tackle the antimicrobial resistance and provide universal health coverage to all. So thank you so much. This ends my presentation.
Thank you so much. That was an incredibly insightful presentation on the challenges and the expectations. And I think that's really powerful to think about what do we expect from the study. And I hope we can pick up on discussing that in the panel as well, like what's after doing the study. So, but now let me introduce Dr. Kimde from the Clinical Research Unit of NANERO in Burkina Faso. And he's going to give us the experience from Burkina Faso and the expectations and experiences. So please, Francois, over to you. Thank you.
Okay, thank you, Sabine. Thank you to give me the floor. Like you said, my name is Kimde Francois, the DIS Accelerator Project Coordinator in Burkina Faso. Project conducted in collaboration with Van Geneva and the University of Oxford. So I'm going to give you to share with you the experience of Burkina Faso in the topic that we are discussing today in this panel. So, okay, what is the antibiotic situation in the Burkina Faso? As you know, for the adequate management for febrile disease, we need to follow the schema presented in this slide. Firstly, we need the clinical diagnosis based on clinical signs and symptoms, supported by a biological diagnosis to confirm or not the clinical diagnosis. And after that, we have the adequate prescription based on the clinical and biological diagnosis. And after that, we can have the adhesion of a health worker and also the patient of the caregiver. In the resource-limited country, the lack of biological diagnostic at primary healthcare center have created a dilemma, and all prescriptions are based on the first point that we said here, the clinical diagnostic. You agree with me that in that condition, it's often difficult to have an adhesion to the prescription in the case that all the adhesion and health worker in the patient and the care and the healthcare giver. So, however, correct diagnostic and the fight against antimicrobial resistance are our fingertip. Why we said that? Because nowadays we have point of care tests available in the market to screen the different etiology cause of fever. And the second point is to reduce inappropriate prescription practice based on the behavior change. And the last point would be the regulation of the sale of antibiotics in the market. But in this project, we are more focusing in the two first points, the appropriate diagnosis and the reduction of inappropriate prescription of antibiotics. It's important to mention that in primary healthcare center, the only point of care test available to screen febrile disease remains the malaria additives. And the consequence, when the malaria additive is negative, is the systematic prescription of antibiotics in malaria negative additives. And when the additive is also positive, we also have some prescription of antibiotic adding to the anti-malaria. And the reason of this trial is to not miss the real cause of fever by prescribing antibiotics to the person depending to the additive result. And the risk is the non-adherence of healthcare workers because they are faced to a dilemma because they don't know what is the real cause of fever in that cases. So for the better understanding of the last point, to understand of the antibiotic practice in the community and design a point of care and training and communication package, we conduct some qualitative research before and during the implementation of this diagnostic accelerator study. In this slide, you can see the data collection method that we are using for the qualitative research, and also the participant that we interview during the qualitative research, and also the software that we are using for the analysis. So the main finding of the preliminary, the pre-implementation period on the factor that can influence the adhesion of the prescription is summarized in this slide. And the individual factor is patient believing and also the fear of the treatment. One point also that can influence the adhesion of the prescription remain timely presentation at the healthcare facility, because patients sometimes come late at the health facilities. And there are also the understanding of the prescription, because sometimes participants or patients do not understand the prescription that when they have to take the medication and how much per day. The last point in that point is the forgetfulness and the use of triggers and aid. It's important also to mention that peer and parent also have an influence for the adherence to the prescription, and at the healthcare level, the accurate diagnosis and the prescription also play an important role. Like I said you before, at the primary healthcare center, the only diagnosis tool available remains the malaria additives. And other point is also the drug storage at the health facilities and the staff available, and the time also took to take care of the different participants. So, on the question, how does communication influence patient adhesion? Healthcare workers share their experience with that, and he said, first of all, between a patient and the healthcare worker, if there are no communications, there are no care, because you can do the diagnosis, conduct a good treatment, but if there are not a good communication between your patient and yourself, you cannot have the desired result. So I figure that communication is very fundamental between the healthcare provider and the patient. So based on this experience of the care worker, it's important to mention that communication is the cornerstone of human daily activity and also contribute to the illness recovery. Also, we report some bottlenecks on the non-adhesion, and between them, there are the ineffective communication of the healthcare worker. Patients must deal with the different types of drugs available at the different health facilities. And patients also sometimes don't have a resource, and the education also play an important role in the adhesion. So, the training and communication package designing on the funding of the pre-implementation period has been implemented during the enrollment and the follow-up study. And we present you some factors that can facilitate the adhesion. And you can see that on day zero communication, during the implementation study, the enrollment and the follow-up, on day zero, example of strategy has been shared with the healthcare worker based on an interview with patient of caregiver. Also, during prescription, tics are used to explain how to take medication correctly. For example, write on table or use school hours to indicate when to take the medication. It's also important to mention that healthcare for children under 5 years is free in charge in the Burkina Faso. An interview of a patient after the day zero process is reported in the slide. And we can read that when we went there, they told to try to follow the prescription, and that if we want to give the medication to the child, we would not force him. That if we want to give him the medication, there are many ways. you can coach him into taking the medication. And he should not take the medication with force. We also agree, and when we coach the child, he accepts. That is the kind of experience that we collect at the day zero visit at the clinic. So, according to the barrier to the adherent, there are summaries in this slide. And the belief of the participant also play an important role in the non-adherence. Sometimes patients believe that their recovery don't, so they stop the medication. Also, the caregiver present at day zero sometimes change. You can have the mother or sometimes the father or the co-wife who bring the participant when we are children at the clinic. Also, the caregiver lack of trust, and also the misunderstanding of the explanation on the cause of fever, and sometimes the medication play an important role on the barrier. The fear also that the recommendation treatment regime would not be harmful to the children, because in the study we more enroll children under 5, and patients believe that treatment would not work also. And that one is also part of the barrier to adherence at the clinic. And we can see some experience of data collected in the clinic. And the second one said, I choose, it was 3 tables a day. And I choose, if I gave him 3 tables a day, that would be dangerous for him. So every morning I gave 1 table. At midday, I gave 1 table, and I gave the third one at the evening after dinner, because his body was very hot and he was convulsing. So sometimes patients think that giving 3 or 2 medications at the same moment can be dangerous for the patient, and they prefer to delay some taking of a medication. Also, some other factors that can influence the adherence should be the difficulty access drugs, the drug stock out, and also the problem of transportation. The third one, when there are not medications at the health facility, participants needed to go to another place to procure the medication. And this one also could be a problem to the adherence when they have not money to move to another place to pay the medication. So we also have an interview of the healthcare worker on the use of the diagnostic, and about the experience that we get with them. The preliminary study is reported in this slide. For example, for the first point, the prescribing based on the additives with some exception. What is the exception sometimes? Participation with fever and without malaria symptom, sometimes the elder worker prefer to give anti-malaria to this patient to avoid the low parasitemia, because they know that the additives have some sensitivity and cannot pick up the low parasitemia. So they prefer to give anti-malaria to not miss low parasitemia. And there are sometimes the long course leading to wrong diagnosis. And you know, sometimes with the malaria additive, there are some specific issues. About the existing challenge using algorithm, some relative to give an opinion about that confusion needed, and some repetitive conclusion, not semiologic value, and the test stock out also is a challenge for our rural area. And like I said before, the community also have an influence, and some patients want some specific treatment when they come at the health facility and you don't give them specific drug. Patients do not believe that you take care of them. And sometimes patients also come with some diagnosis in mind that they need to be tested. And for the last point, we needed of training on the use of algorithm. Some preliminary training is not given to the healthcare worker before doing the service. And sometimes they prefer to learn with others with a limited knowledge. This is the end of my presentation. Thank you very much.
Thank you so much, Francois. That was really exciting to hear to get some of the early results from the qualitative work. Really, really exciting. And I would ask all my colleagues to join me on the panel, join me on a virtual couch to have a discussion and to maybe speak a bit more about some of the aspects. And one thing I would like to sort of maybe get to at the outset, like this, we've talked about the vision of the study, how it was implemented in some of the countries, but what is unique about it? And I don't know, Juvenal, whether you can still hear us and join us, but from your experience, is there, what do you feel is different about the way we've approached this and how it maybe can be translated? Because then next, I think it would be exciting to speak about a little bit how this could be used and what are the next steps into, moving from a study and from research data into policy and maybe implementation on a bigger scale. So, but first, what is, what's sort of unique about the current approach?
Yeah,
I know you're having connectivity issues, so let's try.
Yeah, I can't switch on my video, but to answer your question, what makes this unique is that right from the beginning, this study was designed while factoring in local expertise. So the study design included local research scientists, it included local policy and decision makers and other members of the local community who are going to benefit from these algorithms. So I think it is for any research, for any evidence, it's always important to have local input, so that because they are the experts on the ground, they know what works and what doesn't work. That is one. And two, looking at the technical part of it, this is a pragmatic study in that the protocol, the site-specific protocols were designed to mirror what is happening on the ground. So you will find there are some differences between the different countries. You find what is happening in Ghana is a little bit different from what is happening in Nepal. And this is usually tailored to mimic what is going on in the country. Even the diagnostic algorithms themselves, they are not the same across the board. So you find in Ghana, we are testing for malaria, we are testing for RSV among children, we are testing for strep pneumonia, the common causes of flu. And then when you go to India, you find we have chikungunya, we have dengue, we have other causes. So that is something that is specific about this study. Then the other important point to note is that we are testing a package of intervention. Unlike other classic trials where you pick one drug or diagnostic and you measure whether it is doing it, the whole context in which the diagnostics are going to work. When a patient walks into the clinic, they are not going to just have a malaria test. They are more likely going to have more than one test, because the doctor has a differential diagnostic, a list of differential diagnoses. So you think it is probably malaria, but it could be strep pneumonia, it could be dengue, it could be. So in the real world, it's not one test at a time, it's many tests, and there's a lot of things going on. So we have things like training and communication. That is a very important intervention. As Francois and Rita have mentioned before, that patients come with a lot of beliefs, they come with a lot of expectations, and so you have to, apart from just testing them and giving them the treatment, you always have to educate them. So the fact that we are testing all this together makes this a very unique study and a unique approach to fever management. So if we could show that actually it works and it is safe, then it should be adopted by most of the countries, including the high-income countries.
Thank you. I think that would be great if we can get to adopting this everywhere. But I want to come back maybe to the test, because I think one of the unique aspects of this, from my perspective, from a product development partnership, which is what FIND is, where we often develop tests. So this is quite unique in the sense as well that we're using tests that are commercially available. We're not developing them. We're not testing any new tests. We're testing a package of existing tests, which is something that's quite unique in the context. And I would like to maybe get a feel from how this, Francois, from your experience using these existing tests. They're all commercially available, but what was your experience really using them in this study now, and in an intended use setting, as we say, or in the real world?
Thank you, Sabina. And then in Burkina Faso, the tests are performed by a nurse assistant, and we call them agent itinérant de santé in the French. And the education level is a secondary school. So the more important thing to mention that we don't need a high qualified technician to perform the test. And also, depending to the number of tests that we have to do, sometimes we need 15 minutes to perform the test and do the prescription to the participant. And also, the easy readout system of the test let them easy to be performed at the health facilities. And this is an advantage for proper diagnosis and reduce inappropriate prescription of antibiotics in the rural area. And that is what is needed in low and middle income countries to improve the diagnosis and the inappropriate prescription and of antibiotics. So if you wanted to implement all these tests at the rural area, because we are using the MOQ machine for the white blood cell count and also for the CRP, and the test needs some temperature to perform very well. We need to adapt this machine in tropical area where we have some time and some auto temperature. Then we will reduce the cost to rolling out the test in the rural area, and also the dependence to the energy source. That is my experience with the implementation of the test in the rural area and tropical region.
Thank you. I think that's really, really insightful, because basically these tests exist, they are commercially available, we can buy them, but maybe not all of them are perfectly suited right now to be implemented in rural areas. So thank you very much. I think that's something to take away for us, that there is still work to be done in this space as well on the development side. Thank you. Maybe, Phil, from your perspective, from the social science, we've heard some of the results from Francois, from the Burkina Faso team, but maybe you could give a little bit more of an insight into the work. I know this is quite unique to the study, and it's a unique thing for us to do as well at FIND, to approach this with the social science aspect, to include that in a study. Maybe you could give a little bit of an idea of how this could be translated, and what that, what this sort of means for the project and for the wider implementation. How do we use this data?
Thanks, Sabine. So I think what's interesting here is that we've really tried to take a local approach to understanding what's driving behaviours, and then put in place some interventions that are sort of specific, addressing those that understanding which we've gained from the localized research. So I think that's particularly interesting, and it means that we've got these sort of slightly different set of messages which support adherence to prescription, which are in the different countries. We see some overlap between them, but we also see some differences. I think that's sort of an important point, essentially, that you need to understand how people behave and why they behave in your location, and then use that knowledge, you can start putting in place some measures to tackle that. It's, we're getting to look at the findings, the analysis. It's looking like these training and communication packages are a successful part of the intervention. And we could imagine that this can be rolled out in hospitals and clinics more widely, in health systems more widely, essentially making sure that doctors are interacting, communicating well with messages that really hit home for the patients in front of them. There will be some other challenges. We're going from a research setting here to a broader health system setting. There's issues such as how long do healthcare workers have with their patients to do diagnostics? Do they have time for some level of communication? And perhaps some traditional, perhaps cultural aspects of how doctors relate to patients and the kind of relationship that they have. And perhaps in some places we need to break that down to have better communication and two-way communication between the two. But certainly this is an exciting piece of work. We've included this training and communication intervention, but also using the behavior tools that we have to develop recommendations which go beyond the communication messages that you might give from the doctor to the patient. So we know there'll be a number of other things within societies, within communities, other ways that you can try and support adherence, prescription adherence behaviors. And we're using the behavior change wheel as a behavioral technique, using that process to help us generate recommendations for that broader change. I've been quite encouraged. I've just seen that WHO is launching a new toolkit called Tailoring Antimicrobial Resistance Program. It's a new toolkit, and it uses pretty much the same behavioral techniques that we're using in the study. That's behavior change wheel, COM-B. We're also using the TDF. These are behavioral change frameworks that we've incorporated in. So I'm very positive about the experience we've had using these techniques, and I think it sharpens the tools we have, the intervention tools we have.
Great, thank you. And I guess it's very encouraging that the work that we're doing links or is in line with what the WHO is recommending in their toolkit. So hopefully, we can feed back some of our learnings on this to the WHO, and the same way we can use this to move forward. So that's great. Dr. Lita, you spoke quite, at the end of your presentation about the expectations of, being part of this accelerator study and the study in general. And so I would like to ask you, first, what is next? Like, how do we turn this, what will be great data, I believe, and what will be really interesting, from a scientific perspective, but also how do we turn that into change and policy? We've deliberately, taken this, altogether, this approach to understand the local needs, the local messaging. We were using tests that are commercially available. So in theory, one would think this should be relatively easy to move into sort of wider use, but we know it's not. But what from your perspective, and maybe specifically for your country, do you see what needs to happen after we have the data to move this forward and take this on and the results into policy change or wider use of these interventions?
Yeah, thank you, Sabine. Actually, I would again like to mention that in Nepal, this is the first ever study that has, both the behavioral part and the quantitative part. So the behavioral part in the sense that, the packages, training services to the patients and also to the health care people. So my expectations, or the expectation that we are, waiting for, I think, maybe the results of this study, so that we can, show the findings of the study to the stakeholders, or, to the Ministry of Health and Population, and this can potentially influence them to invest, or, to fund, to train the health workers, or also to get the RGTs, or maybe make it accessible to even the primary healthcare facilities, where I mentioned in my presentation also that no tests are there. So people are using, in a country like Nepal, antibiotics are being used like anything rampantly. Even if we talk about COVID-19, if I have to be specific, then even though the guidelines are there, antibiotic like azithromycin is being used like anything, even if they have a fever or COVID or whatever. Drugs like like antibiotics like these are being used like anything. So maybe in a country like ours, this study and this particular quantitative and qualitative part both will be really like useful to tackle all these problems. So hopefully we are looking forward to the results of this study. We're trying our best. The protocol amendment is there. We're trying our best to get the enrollments going on, and then so that's it. Yeah, thank you.
Sorry, rookie mistake. I was muted. Thank you very much. I think that's that's great for the outlook. And maybe just as a last question, similar question to Francois, from his perspective, in Burkina Faso, what are the next steps? What needs to happen and on multiple levels to take the results of a study like that, to the next step, which is a more practical implementation and use more widely. What do you think? What is your vision, and what have you maybe already, what steps have already been taken?
Okay, thank you, Sabine. Like the main beneficiary of the funding of this project remains the Ministry of Health. So for that, I think we need a pilot essay with the Ministry of Health, try to work in the real condition, because in this project, we are involving nurses and nurse assistants to perform the tests and do the different prescriptions. Now we want to see how it's work in the real condition and what is the real benefits for the Ministry of Health. And that this pilot essay can be considered like a pre-rollout of a point-of-care test in the rural area. And for that, it's important to involve in this rollout of the test on the rural area, which is the pilot essay. We need to involve the different partners of the Ministry of Health. And when I talk with different partners, it's the international partners, where we have WHO, UNICEF, and also USAID, who support the Ministry of Health on the different strategy to improve the health care of different populations in the Burkina Faso. But locally also, we need to also involve some partners. And for example, we have the generic drug purchasing center, who have the mission to provide the different drugs in the countries. And also some drug regulation agency in Burkina Faso need to be involved to show them the benefit to implement the different tests in the rural area. And in Burkina Faso also, we have a National Health Insurance Agency that work to give an assurance to the different population. And it's important also to involve these partners to the pilot essay that we propose. And there are also some organizations and associations working on IMR that could be also important to invite them to the pilot essay. And this, in my point of view, we can have an important impact on the adhesion of the different stakeholders based on the benefits of the implementation of the point-of-care test. Then it could be easy to translate the finding of this project at the policy at the rural area. This is a little bit my point of view. And other point that I prefer to mention, by involving the different partners, the more important for the government is the cost, how the implementation can cost. And the different partners also support the government with some money to try to make everything available and easy at the different health facilities. So If we have this pilot essay with the different partners that I listed here, it could be easy to translate the funding of this project into policy. And I think WHO can play an important role in this process.
Well, thank you. I think these are very positive words, and maybe we should close the meeting and this chat with these like positive outlook that if there is engagement across different sectors, and if we can if there's engagement across agencies, that there is an opportunity to take these data and really move them into implementation, into wider use. And that really is the vision and the hope that the data that are generated in this very rigorous way, that they can be translated and can be used to change policies in country, but also support the WHO or other agencies internationally with data on multiple areas of how we can use diagnostics and other interventions to help tackle AMR. So thank you very much, all of you, for joining this webinar and for joining this panel discussion. I'm going to close the meeting with this and thank everybody for joining. This was really exciting, and please do have a look at our website, at FIND's website, to learn more about this program, other programs that we have, and also about this webinar series where we will be talking next about the FIND Innovation Platform, which is a platform where we specifically work with partners on advancing next generation malaria RDT tools. So that's more around development and less about implementation. So please do join us for the next call, for this next webinar, and thank you again for joining this really exciting panel and topic. Thank you. Bye-bye.